Hello, I'm Dr. Pratyusha. Today I am here to discuss the topic preterm labor. So, going with the definition, preterm labor is defined as one where labor starts before 37th completed week of gestation, counting from the first day of last menstrual period, that is, less than 259 days of pregnancy. So, what is the etiology? What is the cause of preterm labor? In 50% of the cases, the cause of preterm labor is not known. So we have few high risk factors that can be taken as a risk factors which can precipitate preterm labor. But in most cases, that is nearly 50%, the cause why the preterm labor has occurred is not known. So what are the high risk factors? Based on the history, the high risk factors are previous history of induced or spontaneous abortion or a preterm labor, which will give you the idea that there might be some cervical incompetence that is present, which is leading to preterm labor. Pregnancy following assisted reproductive techniques, asymptomatic bacteriuria, recurrent urinary tract infections, or any infection that is occurring during pregnancy can also lead to a preterm labor. Smoking habits of the women, low socioeconomic and nutritional status, and maternal stress. So these are the risk factors. Based on the history, you can ask the patient to know that she is at risk of preterm labor. So what are the complications in the pregnancy? So the maternal complications in the pregnancy that can lead to preterm labor are preeclampsia, antepartum hemorrhage, premature rupture of membranes, and polyhydramnios. Preeclampsia, it can be an iatrogenic cause. If it is a severe preeclampsia, we need to deliver the woman, that will be a iatrogenic preterm. Antepartum hemorrhage, either abruptio placenta or placenta previa, where we need to deliver the patient in case of fetal-maternal. When there is excessive blood loss, we have to deliver. In such cases, premature rupture of membranes, which might be due to any infection or there is leak. Then we have polyhydramnios, where there is increased in pressure and there can be a leading to a preterm labor. So these are the maternal complications in the pregnancy, that is the present pregnancy, which can lead to preterm labor. Then we have the uterine anomalies, that is the cervical incompetence and malformation of the uterus. Then we have medical and surgical illnesses which can occur in the present pregnancy and lead to preterm labor, that is the acute fevers, pyelonephritis, diarrhea, acute appendicitis, toxoplasma, and abdominal any surgeries. Chronic diseases like hypertension, nephritis, diabetes, decompensated heart lesions, severe anemia, and low body mass index. These are all the risk factors that can also lead to a preterm labor in the present pregnancy. Then we have genital tract infections, that is the bacterial vaginosis, beta hemolytic streptococcal infections, chlamydia, and mycoplasma, as well as the bacteroids. Then what are the fetal factors that can lead to preterm labor? That is multiple pregnancy, congenital malformations of the fetus, and intrauterine death. The placental causes are the infarction, thrombosis, placenta previa, or abruptio placenta. These are the causes in the present pregnancy. Then, as we have discussed, iatrogenic, due to medical or obstetric complications where delivery is impending and we have to deliver the women. Idiopathic, where 50% we don't know what is the cause, that is the premature activation of the systems involved in initiating of labor at term. Those are activated early and will lead to a preterm labor. So how do you diagnose? When a patient has come to us complaining of pain, how will we diagnose that the patient is in preterm labor? She will have a regular uterine contractions with or without pain, at least one in every 10 minutes. We can diagnose this by at least palpating on the abdomen or the uterus and with the help of a toco. So that is one thing, regular uterine contractions. Dilatation and effacement of the cervix. The cervix should be more than 80% effaced and more than 2 centimeters dilated. Length of the cervix as measured by TVS transvaginal scan is less than 2.5 centimeters and there is funneling of the internal os. Then there is pelvic pressure, backache or vaginal discharge or bleeding. So these are the diagnostic criteria when a woman presents to you with complaints of pain. So these are the diagnostic criteria when you can suspect that she is in a preterm labor. So what is the pathogenesis? What has happened? So first we start with any focus of infection, intrauterine infection, which will mount a maternal as well as the fetal inflammatory response. So the causes of infection can be either transplacental, hematogenous, ascending infection from the vagina or cervix, or iatrogenic from any procedure like amniocentesis, chorionic villus sampling. This will lead to infection, and this infection can mount a immune inflammatory response. So there is maternal inflammatory response which will lead to prostaglandin release and production and remodeling of the cervix, which will lead to preterm labor as well as premature preterm rupture of membranes. There is fetal inflammatory response where there is pro-inflammatory cytokine release, cerebral white matter damage, bronchopulmonary dysplasia, which will lead to neonatal sequelae after birth of the baby. If it is after the preterm birth of the baby, there is neonatal sequelae that can be occurring. So this is the etiopathogenesis of the preterm labor. What is the cause, what is the pathology, and how it is progressing. So now we have admitted a woman in preterm labor. We have diagnosed it. So how do we manage? So management, first it is like prevention, as to prevent preterm onset of labor if possible by detecting the high risk factors early, to arrest preterm labor if not contraindicated, management of labor, and effective neonatal care. So this is the brief outline of management of preterm labor, which we will be discussing in detail. So now what are the predictors of preterm labor? We have the clinical predictors, biochemical predictors, as well as the biophysical predictors. The clinical predictors are history of a prior preterm birth, multiple pregnancies, presence of genital tract infection, and symptoms of preterm labor. So these are the clinical predictors. Then we have biophysical predictors, that is uterine contractions more than 4 per hour, Bishop score more than 4, cervical length by TVS is less than 25 mm. Then we have the biochemical predictors, that is the fetal fibronectin in cervicovaginal discharge is present between 24 and 34 weeks of gestation. So this should be absent normally, but in cases of a preterm labor, the fetal fibronectin is diagnosed in the cervicovaginal discharge. That itself can indicate that the patient is at risk of preterm labor. And we can also find interleukin 6, 8 and TNF. So these are the predictors of preterm labor. Now we have the principles of management. What we can do to help the women. First, we should start with a glucocorticoid to the mother to reduce neonatal respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, bronchopulmonary dysplasia, and patent ductus arteriosus. Steroids. Then, if we don't have a facility to tackle the newborn, we can transfer the mother in utero, that is antenatal transfer of the mother with fetus in utero to a tertiary center equipped with a neonatal care. Tocolytic drugs to the mother for a short period unless contraindicated. So these tocolytics are given till we give a steroid coverage. After the steroids are covered, like that is that 48 hours, there is no role for tocolysis. Antibiotics to prevent GBS group B streptococcal infection. Magnesium sulfate as a neuroprotective agent to the mother to reduce neonatal cerebral palsy when the pregnancy is less than 34 weeks of gestation. Careful intrapartum monitoring and presence of a neonatologist during delivery. So these are the principles of management of preterm labor. Prevention. So how will we prevent? It is primary prevention, secondary and tertiary. Primary is by reducing the high risk factors. Secondary, early detection and treatment. If the woman comes, it is early detection. Treatment with the steroids, tocolytics to postpone delivery. Tertiary, because the birth has already occurred, all measures in neonatal care unit to reduce perinatal morbidity and mortality. So investigations. What investigations we are doing? Full blood count for rule out any infections and anemia. Urine for routine analysis, culture and sensitivity. cervicovaginal swabs for culture and fibronectin, ultrasonography for fetal well-being, cervical length and placental localization, serum electrolytes and glucose levels when tocolytic agents are to be used. Because these tocolytic agents like nifedipine, as well as now actually routinely we are not using, but beta agonist, that is the Preterm, can also be used as a tocolytic agent. In such cases we measure the electrolytes as well as the glucose levels. So what are the measures to arrest preterm labor? And what are the contraindications? First, what contraindications are there, and in which conditions we should not arrest or we should not normally what we do is we give tocolysis and for the steroid coverage to occur so that the baby is well without any respiratory distress after delivery. But there are few conditions where tocolysis is contraindicated and we cannot stop labor. Such conditions are maternal uncontrolled diabetes, thyrotoxicosis, severe hypertension with imminent features, cardiac disease, and hemorrhage in pregnancy. So in these conditions we cannot give tocolysis and we have to allow for the preterm labor. And the fetal conditions are fetal distress, fetal death where there is no point in prolonging pregnancy, congenital malformations, and pregnancy beyond 34 weeks. There is no much role for tocolysis and steroid coverage and you can allow for a preterm labor. Then there is rupture of membranes, choriamnionitis, and cervical dilatation more than 4 centimeters. So grossly we have like conditions like infections or any hemorrhage, fetal death, and severe maternal medical conditions where there is a contraindication for tocolysis, where there is no point in prolonging labor. So how will we manage a patient in preterm labor? First stage, as like in a normal laboring women, in first stage we can ask the patient to rest, give some pain relief. Continuous electronic fetal heart monitoring is done where the fetal well-being will be assured, and cesarean section is only for the obstetric indication. And in the second stage, the birth should be gentle and slow to avoid rapid compression and decompression of the fetal head, okay, which can lead to intraventricular hemorrhage. So the birth should be gentle and slow. Episiotomy may be given to minimize head compression if there is severe perineal resistance, and tendency to delay is curtailed by low forceps. But as such, routine forceps is not indicated. And less than 34 weeks of gestation, the venous delivery where the vacuum cup is used, that is also contraindicated. And we should, at the time of labor or during before labor, we should also ascertain the presentation, because in a preterm birth mostly there might be a breech or a malpresentation which is also present. So the presentation of the fetus should also be ascertained before the progression of labor. And the cord is to be clamped immediately at birth to prevent hypervolemia and hyperbilirubinemia. So this is the care that we are taking during the second stage of labor for the baby delivery. And cesarean delivery is done only for the obstetric indications, and definitive indication for cesarean delivery in a preterm birth is a preterm breech presentation, where there will be difficulty in delivery of the aftercoming head. So a cesarean section with a vertical incision on the uterus can be done for the preterm breech. Then we are discussing the preterm premature rupture of membranes. PROM stands for premature rupture of membranes. So by definition it is spontaneous rupture of membranes any time beyond 28th week of pregnancy but before the onset of labor. It's called pre-labor rupture of membranes. It can be prolonged rupture of membranes for a period of more than 24 hours. Term PROM by definition is rupture of membranes occurring at term, that is after 37 weeks but before the onset of labor. Then it is preterm PROM, that is less than 37 weeks of gestation. So these are the definitions: rupture of membranes, term, preterm, and prolonged rupture of membranes. So what are the causes? The causes of early rupture of membranes are increased friability of the membranes, decrease in tensile strength of the membranes, polyhydramnios, cervical incompetence, multiple pregnancies, infection like the chorioamnionitis, urinary tract infection or lower genital tract infection, cervical length less than 2.5 centimeters, preterm labor, and low BMI that is less than 19 kg per meter square. These are the causes where we can anticipate a early rupture of membranes. So when a patient presents with rupture of membranes, what investigations we can do to the patient and how will we evaluate the patient? Right. Now let us discuss about how a patient with premature rupture of membranes present to us and how we diagnose. So presentation, she will come with a complaint of leaking of water per vaginum, or she will tell you that there is leakage of fluid per vaginum or with a soaked dress. So she will present, and how can we diagnose? We can do with a speculum examination where a speculum is inserted in the vagina and we can see a clear fluid coming out of the cervix. That is one speculum examination where we can diagnose. And to examine the collected fluid from the posterior fornix, we have collected the fluid with the speculum and we examine it for detection of pH by litmus or nitrogen paper. Normally the vaginal pH during pregnancy is acidic, that is 4.5 to 5.5, but like an amni it is 7 to 7.5, the pH becomes 6 to 6.2. So because the pH has become more than 6, the nitrogen paper turns from yellow to blue. So this is one nitrogen paper test for detection of liquor in the vagina. Then from the collected fluid we can go with the centrifuged cells. We can centrifuge the fluid and the cells are stained with 0.1% Nile blue sulfate, which shows orange blue discoloration of the cells. So these cells will give you identity that they are exfoliated fat cells from the sebaceous glands of the fetus. So centrifuge test, amnisure, a rapid immunoassay is accurate, and ultrasonography. So in ultrasonography we can see the liquor pockets. We can see each single pocket depth, single deep pocket, what is the measurement, or total AFI. If it is less or if the single deep pocket is also less, we can assure that there is continuous leak of fluid and there is a premature rupture of membranes. So to consolidate, we have this vaginal pool, that nitrogen paper test, the centrifuge cells test, where there is taking a orange blue discoloration of the cells, amnisure, and a ultrasonography. But the first thing is by a clinical examination, that is a speculum examination. And one important thing to mention here is whenever there is early rupture of membranes or the premature rupture of membranes, a speculum and a vaginal examination is important, because there is a chance of cord prolapse if there is a malpresentation or the high station of the presenting part. So that also has to be ruled out. So after diagnosis we come to the investigations. We go with a full blood count, CRP, because one important cause of any PROM or preterm labor is a infection. So full blood count, CRP, urine for routine analysis and culture, high vaginal swab for culture, especially for the group B streptococcus, that is a GBS infection, where if the swab is positive we can give a prophylactic antibiotic course to the women, because the risk of infection to the baby after delivery is also high and the baby has to be monitored after delivery. Then vaginal pool for estimation of phosphatidylglycerol and lecithin sphingomyelin ratio, which denotes lung maturity of the fetus. Ultrasonography for fetal biophysical profile, which gives you a score of 8 by 8, and if the NST is also added, can be 10 based on the biophysical profile score, or a modified biophysical profile score will give you the fetal well-being idea. Then cardiotocography for the non-stress test. If there are no contractions, we will see how is the fetal heart and how is the fetus responding. So these are the investigations, blood investigations to detect infection and scan and a tomography to identify or to ascertain fetal well-being is also important. Complications. So what are the complications that can occur in a PROM patient? In term PROM, once the rupture of membranes is occurring at term, in such patients, in 80 to 90% of the cases, labor starts in 24 hours. So that is one thing which is good, that is labor will be starting. She will progress on her own. And PROM is one of the important causes of preterm labor and prematurity. The chance of ascending infection is more if labor fails to start within 24 hours. Liker gets infected because the membranes are ruptured, and there is always a chance that there is a ascending infection because the vagina as well as the genital tract has so many microbial organisms. It is colonized. So Liker gets infected and fetal infection supervenes if the labor has not occurred or not delivered in 24 hours. So that is chorioamnionitis can occur. The other complications are cord relapse. Dry labor, when all the liquor is drained out, the patient will go into a dry labor, which can later lead to dysfunctional labor, difficulty in delivery, increased operative delivery, as well as increased need for cesarean sections. Placental abruption, fetal pulmonary hypoplasia, especially in preterm PROM, is a real threat when associated with oligoamnios. Neonatal sepsis because of the infection, respiratory distress syndrome, intraventricular hemorrhage, NEC in preterm PROM. These are the routine preterm complications that can occur, which is also superimposed by a sepsis component if the delivery is prolonged. Then perinatal mortalities, morbidities like a cerebral palsy are high. So these are the complications in a preterm labor, PROM. And what are the maternal complications of PROM? We have chorioamnionitis, placental abruption, retained placenta, endometritis, maternal sepsis, and even death. So all these are due to ascending infection: chorioamnionitis, endometritis, maternal sepsis. Placental abruption can occur because of the sudden leak of fluid through the vagina, which will lead to early separation, decompression of the uterus, and separation of the placenta. So these are the complications that can occur because of a PROM. How do we manage? So management is mostly based on the gestational age and presentation and well-being at presentation. So after 37 weeks or more, that is at term, a patient presents to you at 37 weeks with PROM. So what we do is, in such cases, we ensure that the normal labor can start by in 80 to 90%. So we proceed to delivery by induction of labor, or if the spontaneous labor doesn't ensure in 24 hours, then we go for the induction. Then we give a group B streptococcal prophylaxis as recommended as per the guidelines. We can give the antibiotic course. That is a term PROM. So near term, then we have a gestational age of 34 to 36 weeks, where it is the same as for term PROM. We can anticipate delivery, but again we give a group B streptococcal prophylaxis, as well as look for a steroid coverage if it is needed. Then if it is a preterm 32 or less, then the expected management, unless pulmonary maturity is documented, what we do is we wait. We try to give a tocolysis, expected management till the steroid coverage is done, or we try to take the pregnancy to at least 34 weeks of gestation. So for that we go with the tocolysis, group B streptococcal prophylaxis, and in this, if any culture or any urine culture or vaginal swab is positive, we could start with the antibiotic as per the culture sensitivity, steroid coverage, and also the magnesium sulfate for the neuroprotection is given. So what we do is we try to prolong the pregnancy till at least 34 weeks of gestation, but only if there are no contraindications to prolong the pregnancy. Any contraindications to prolong the pregnancy, like in abruption or the chorioamnionitis has set in, we need to plan for delivery of the baby. And absolutely, like chorioamnionitis, abruptio placenta, absolutely we have to terminate the pregnancy, that we have to plan for a delivery under the antibiotic coverage. And also this PROM, if with any underlying infection, can lead to postpartum complications like postpartum infections, fever, sepsis, subinvolution of the uterus, retained placental bits. So we should be vigilant while delivering the patient and in the postpartum period. Thank you.